What I'm going to talk today is the shoulder. I do have a particular interest in shoulders. I think the shoulder is a wonderful joint. I think that over the years, the shoulder has been neglected. Knees and hips have been a really common issue throughout the years, and we've really developed really well with hip replacement and knee replacement. Some of you may have experienced that yourselves. You may have friends or family members that have. The shoulder is one that has come, a joint that has come to the forefront in the last, I would say probably 15 years, where we've really started to get good at diagnosing, good at treating. We've had treatments for the shoulder problems for years, but we just have gotten better. The implants are better, the techniques are better, and now we have specific trained, like myself, we have specific shoulder fellow trained, meaning we did an extra year in training for shoulder reconstruction. So be over and above my normal orthopedic residency, which was 5 years, I did an extra year in shoulder and knee reconstruction and sports medicine. So this is me. Disclosure slide. This has a little bit of relevance. I don't talk about the implants, but I did receive a little bit of a consultant fee from one of the companies that I use. If the video works at the end, I could not blur a patient's face, but she did give me her permission to show her face in this presentation. So any faces that you see, permission has been given. So what we're going to talk about today is we're going to start off with a little bit of anatomy. If you are all familiar, I'll ask you to bear with me for those of you who may not be familiar. Talk about 4 very common conditions in the shoulder. We'll talk a little bit about exam findings, things that you can self-diagnose, or things that you'll have someone like me or your primary care doctor or another orthopedist may find, and treatments for these issues. And then we'll talk about some, then there will be some time for questions at the end. So starting with the anatomy. 3 bones form the shoulder joint, or the shoulder girdle rather. We have the clavicle, which is the collarbone. We have the scapula or shoulder blade, and the humerus, which is the upper arm bone. The shoulder joint itself is the glenohumeral joint, so between the glenoid of the scapula and the humerus here. There are 2 other joints that comprise the shoulder girdle that can cause problems. We have the AC joint, which is the acromion, that's the top part of the shoulder blade. Clavicular joint, so that's this one here. This doesn't extend down this way, but if we follow this down to the breastbone, there's the sternoclavicular joint, which is right in here, in this area. That can cause problems as well. In the shoulder, though, 97% of the problem, if you're talking about a joint problem, is going to be one of these 2 joints. But those are the bones of the shoulder. We talked about that. I guess we did come down. Next slide. So here's the sternoclavicular joint coming down right here to the sternum. You have the sternoclavicular joint. I put on here a scapulothoracic joint. It's really not a joint, but it is technically what we call an articulation, meaning there is movement between the thoracic wall, the back of the ribs here, and the scapula. The shoulder joint itself, the glenohumeral joint, only gets you to about here, to about 100, 115 degrees. When the scapula is working as it should, and depends on all the muscles, that's where you get your arm all the way up to here. So if you have a muscular problem, that can lead to loss of function as well if we're dealing with the scapulothoracic articulation. Muscles. There are a lot of muscles around the shoulder. There are 17 muscles that attach to the scapula. The most common muscle that everyone knows about is the rotator cuff. And the rotator cuff comprises of 4 muscles. There's the supraspinatus, infraspinatus, subscapularis, and the teres minor. Of those 4, the most common injured is the supraspinatus, followed by the infraspinatus, followed by the subscapularis, and almost never the teres minor. The supraspinatus, if you were to put your arm up over on top of your shoulder and rub this way, right above, you'll feel the spine of your scapula, and just come right forward of that. That is the supraspinatus muscle. That's this one up here on top. That is going to be the muscle that is responsible for initiating the lifting of your arm away from your body. Okay? The back muscles, the infraspinatus and teres minor, they are below that spine. They're going to be the ones that are responsible for rotating your arm out and back. If you're already up in this position, for also rotating back like this. The front muscle, the subscapularis here, if you have your arm down at your side, that's going to be the muscle that's responsible for the strength coming across your body. If you're out away, coming down across your body, it's going to help out with that, along with the pectoralis and others. So those are the four main muscles that we deal with shoulder pathology, but we have all these others. And the bicep here on the front of the arm, the tricep on the back of the arm. Pec minor is a small muscle that comes underneath your pectoralis, attaches to the shoulder blade, and then across to your chest. All these other ones come up and they attach here in the front part of the shoulder blade, and they actually will go up into the jaw, into the back of the neck. So sometimes people come in and they have a shoulder problem and they say, well, why do I have jaw pain? Or why do I have pain going up the back of my neck? Or why do I have pain going down my back? It's because all these muscles try to compensate and cover for the muscle that may already be injured, one of these guys here, and so they spasm, they're not functioning well, and so people develop pain in other muscles of the shoulder girdle. The joint itself. We have this here, we've taken the humerus out of the joint. We're in cross section here. So this is the acromion bone, the top of the shoulder blade. This is that coracoid. Let's come back here. I didn't really talk about that one, but it's a little thumb out here in front of the joint where some muscles will attach. So that's this in cross section. And then you have the joint here. This is cartilage right here. That's the articular cartilage that wears out with arthritis. We don't like to see it worn out, but I got to admit it keeps me in business when it does. The labrum here is a rim of cartilage that goes around the outside of the joint. Now, one thing I'll always try and clarify with people is the type of joint that the shoulder is. A lot of people, we know that the hip is a ball and socket. Is that me? Sorry. The hip is a ball and socket joint. And so traditionally in the past, we've likened the shoulder to that as well and said, the shoulder's a ball and socket joint. The way I describe it to people is it's more like, rather than a ball and socket, it's more like a golf ball on a golf tee. If you tip the golf ball, it's going to fall off. It's a pretty shallow cup. So what this labrum does is it deepens the cup. It also is where the attachments for all these ligaments and tendons are that provide the stability for the shoulder throughout the motion. If you think about the hip joint, you've got a bony support as you're moving the hip, and obviously you can't get your hip and unless you're a gymnast or something, you can't tuck your knee behind your ear. But with your shoulder, you can get your arm just about anywhere in space if your shoulder's working as it should. That's what these ligaments are. This superior glenohumeral ligament, the middle glenohumeral ligament, the inferior glenohumeral ligament. It doesn't show it in the back, but there's a thickening of this capsule down here, which we call the posterior inferior glenohumeral ligament. And there's a posterior medial one as well that's also not a true ligament, but it's a thickening of the capsule. Again, these provide stability for the shoulder. You can see in the back part of the joint, you have this big bony structure. That's the acromion. That's going to help prevent the shoulder from slipping out backwards. The coracoid doesn't do a lot for that, and that's where if we were to get into dislocations, and I'm not going to talk much about that today, but most shoulder dislocations are anteriorly or forward, simply because all you've got holding the shoulder anteriorly is those ligaments. If the labrum tears, then that can lead to shoulder instability and pain, and because those ligaments are no longer attached, you've lost their supporting structures. So here's some arthroscopic pictures. I just got done doing a couple of arthroscopes, but this is looking inside the shoulder from back to front. So here's this corner right here, that's the humeral head. This is the bicep tendon as it's leaving the joint, going out through the rotator cuff. This is the top rotator cuff, the supraspinatus right here. This is looking a little bit further down in the joint. Here's the humeral head there, the cup there. That's a really nice looking joint, no arthritis. And then this is looking further forward. This right here, you can just kind of get a hint back in the background. This is the front rotator cuff. So in this position, I apologize, in this position the patient is lying on their side. So we're seeing the tendon here of the subscapularis as it goes across straight there. What we're seeing here is it is on an angle. So that's that. And then this right here is someone who's had an injury. You can see the difference here between normal, healthy cartilage, and an area where the cartilage has been knocked off the bone, precursor to arthritis. This was a patient who had dislocated their shoulder, and they have a injury to the cartilage of the humeral head. And then again, here you can see that posterior labrum. You can see the nice transition from the cartilage into the labrum right there, and that looks very nicely there. Some plain x-rays. Anytime someone comes to me with a shoulder problem, one of the first things we're going to do is I'm going to say, do you have x-rays? If we don't have x-rays, we're going to get some. What I'm looking at for the plain x-rays is I'm looking at the joint itself. I want to see a nice round humeral head here. There's no evidence of arthritis, nice space between the joint. And again, there's a good example of that, the ball on the golf tee I was telling you about. You can see a nice round head, but it's pretty shallow joint. This one got a little bit washed out in the times I've transferred it from the X-ray to the PowerPoint, but we lost the AC joint here on the top of the acromion, but they're sitting right out here. This is what we call the axillary view. That's a shot that looks up basically through the armpit, looking upwards. Again, I'm getting a different viewpoint of the joint right here. Again, a nice round humeral head. There's the acromion coming across the front. Right here you can see this line right there and there. That's your AC joint between the collarbone and the acromion. MRI picture. So this is also a picture if someone has a shoulder problem that we're thinking it may not be arthritis, it may be more of a rotator cuff issue or a cartilage issue, we'll get an MRI. On this view here, this one's a cross-sectional. We've slit the shoulder in cross-section this way, looking from front to back. This is the humeral head here. We have the top rotator cuff, that supraspinatus coming right through there and attaching right out there really nicely. This is the top part, that's the acromion. This right here is the cup. The top part of the labrum there, and you can see this right here, this black line is the line of the bone. This right here is the labrum, and then the gray in between, that's the cartilage. So this person has a little bit of thinning of the cartilage up top, and you don't see the cartilage too well on the head, but it is there. On this is a better view of the cartilage. This is a cross section. We've sliced the arm this way in cross section. So this is the humeral head. This is the bicep tendon in front. This is the front rotator cuff, the subscapularis, the back rotator cuff. Here's the posterior labrum. There's the anterior labrum, and again, there's the bony margin. So the gray from here to here is the cartilage. So a nice thick cartilage layer there. And then on the head, that black line right there is the bone, and the gray right here is the cartilage. So we've got a nice thick layer of cartilage on this humerus. So this person has no arthritis. This is a very nice looking MRI. No problem there. I didn't mention, if you have any questions as we go, don't hesitate to raise your hand and holler out. If you have any questions about the anatomy, I'll answer.
I just wanted to ask, what does arthritis look like then?
Okay.
When you see it?
Okay, very good question. So the question was, what does arthritis look like when I see it? Coming back to this arthroscopy picture, the whole humeral head would look kind of like that, only yellowish, because the bone underneath the cartilage is yellowish. I do have some x-rays in a moment that we'll get that I'll explain to you and show you what the arthritis looks like on x-ray. Okay? Any other questions about the anatomy before we move on to conditions? Okay. All right, so the common conditions we're going to talk about today, they essentially, except for this one here, the arthritis, we'll talk about that one. The other three all deal with the rotator cuff. I would say probably if I were to put arthritis out, and I really can't because again that's a big issue, but rotator cuff issues in patients that I see probably comprise 65 to 70% of what I see in the clinic. If I add arthritis in there, that probably would bump to what I see in the clinic. Approximately 90 to 93% of patients that come through my door are coming through with one of these problems. Younger patients will come in with instability, and then I'll see a smattering of other things here and there, just random things, for instance. So we'll start off with the impingement. You may have heard bursitis, tendonitis. It's essentially another name for the impingement. We'll talk about rotator cuff tear a little bit, and then again arthritis. And this rotator cuff arthropathy is where we combine these two. We have a large rotator cuff tear that has either been there for so long it can't be repaired, or it's so large I can't repair it. With arthritis, that leads to very dysfunctional shoulder that, as we talk a little bit more, in the past has been one we'd say, well, sorry, we can't do anything for you. Again, this goes back to what I said earlier. We've had a lot of great developments in the last 15 years, so now I can look you in the eye and say I have a pretty good treatment for that. So impingement. Again, back to the anatomy here, we have the clavicle, the acromion here. It's kind of overshadowed by this white part representing the bursa. The humerus here, and so we've got the muscle. This is the front rotator cuff there. The scapula is down here, this coracoid there, and then these are ligaments that are important for the stability of the scapula and clavicle, also for the shoulder. There is a bursa, and what a bursa is it's actually not a sac of fluid. Some people tend to think it's a sac of fluid. It's more a potential space, that if there becomes inflammation, that's where the inflammation is going to be. When I do a shoulder surgery, that's what I'll fill that area with fluid so that I can actually see to work when I'm doing a rotator cuff repair. But as we're sitting here now, most of us probably have just millimeters of space in that bursa. But what happens with impingement is there's an inciting event. It can be an injury like a fall, someone pulls on your arm. I've had patients tell me they're walking the dog chases a squirrel, jerks the arm, this sort of thing. Hit your shoulder on a wall. I've had patients tell me I just woke up with it. The other thing is overuse. I see it a lot in people who are doing a lot of work overhead, away from their body. I see it in a lot of workers with that, and also see it when patients do activity that they don't normally do. For example, 3 months ago, I was seeing a lot of people coming in and saying, my shoulder hurts. What have you been doing? Well, I've been putting Christmas lights up. They don't put Christmas lights up year-round. It's something new. They're reaching and doing this sort of thing, and so it bothers their shoulder. That's more in the realm of an overuse. Yes, ma'am?
What does corticoid process do?
The corticoid process, that's that little thumb of bone I was telling you about that sticks out in front of the cup, the glenoid. That's where it's where these ligaments attach. It's also where the bicep muscle attaches and a couple other muscles. Okay? So the impingement, what that is I wish the bursa were not here. But what it is the top rotator cuff, as it comes in here and attaches. Let me come back to the cartoon. Right up here. As you lift your arm, you can imagine if there's a spur here, a bone spur here, and you lift your arm, you'd be pinching this tendon between the bone of the humerus and the bone of the acromion. Very painful. And then what that does is it gets this bursa inflamed right here, that then it becomes really red, inflamed, really painful. The nerves get all irritated. And then it can also irritate this ligament and cause this ligament to hypertrophy or grow. I've seen patients that don't have a very big bony spur, but I go in there and this ligament looks like a carrot, and so I end up having to take that ligament out because it's what's pinching on the rotator cuff. So that's the impingement. So this is what we see on the impingement. Well, the main symptoms are going to be pain, weakness, and loss of motion. Pain is mostly with overhead use and away from the body. So again, those people that come in and say, well, I was doing my Christmas lights, or I was doing a lot of painting, this sort of thing, that's where we get the pain, is away from the body and overhead. Weakness, and again, the weakness is going to be weakness getting something off the top shelf. I get up there, I have to use my left arm or my other arm to help get it down. That can be impingement. Night pain is very common. People come in and say, I do okay during the day, but as soon as I lay down at night, gosh, that shoulder just hurts. Taking an anti-inflammatory like ibuprofen will leave. It just isn't working. Nighttime just really hurts. And then loss of motion is not necessarily because the shoulder itself won't move there. It's because it's too painful to move there. If you've had shoulder pain, you get to a certain point, your shoulder hurts, you say, I don't want to go anymore. That's your brain saying that's a protective mechanism to not cause the pain and not cause the inflammation to worsen. A couple of things on exam, you may hear your doctor talk about these. These are just exam findings. This near sign, what we're doing here, this gentleman here, we're lifting the arm up, and actually it doesn't quite fully show it. His arm should be rotated so the thumb is down. The way I do this is I test it with the thumb down, and if that hurts going up like this, I'll then turn you with your thumb up or your palm up, and there often is less pain going palm up. And that just goes back to where the rotator cuff attaches on the bone. If your thumb is down, I'm rotating that rotator cuff into the bone spur. When your palm is up, I'm rotating the rotator cuff away from the bone spur. So that's the near sign. The Hawkins sign here, we're demonstrating here, we bring the arm out in front like this and rotate the arm down. And again, what that does is it rotates that rotator cuff into the bone spur or that ligament here, and that causes a lot of pain and pinching there. What causes the impingement? We went back to overuse or injury. There's also normal anatomy that can cause it. We talk about bone spurs on the acromion. Most of the time, patients don't have an acromion like this, and all of a sudden we develop a bone spur. Most of the time, it's just something you were born with, the injury or overuse caused the problem, and now all of a sudden it won't go away because you have that bone spur there, and we got to take care of it. If the non-surgical treatment doesn't do it, then the surgical. But we have 3 different types of acromion. So this cross-section, what we're looking at, this is plain x-rays. We're looking at the shoulder from this direction, back this way. So we see, try and get a good view. There's the shoulder blade there. So here the shoulder blade is overlapping the humerus, and here it's overlapping the humerus as well. This is what we call a scapula Y view, because if you look at the scapula, it looks like a Y right there. So the acromion comes up here. This is the collarbones. This is your AC joint. And you can see on this one, this is what we call a type 1. You can see there's a nice smooth curve from the acromion into the into the collarbone. That's going to give plenty of space in there for that rotator cuff. A person with this kind of a shoulder blade who has impingement is going to be more likely to be one of those people with a very inflamed bursa or really hypertrophic ligament. This one here, you can see there's just a little bit of a step. It comes up flat, and then just a little bit of a curve there, but there's a little step there. That's a type 2. And then this one comes over flat, and it just makes almost a right turn right there, and you've got a nice little shark tooth. And that one can be, the bone itself can be the precipitating event that causes the problem. So treatments for impingement, we always start non-operative. If you've had this before, you've probably had this experience, either with an orthopedist, with a primary care doctor, with a physical therapist. Start off with some physical therapy, either a formal program with a therapist or a home program, working on the mechanics of the shoulder blade, trying to get things back to normal. These 3 should be slid over, I apologize. Cortisone injection. What I'll do there with a cortisone injection, I'll put that right in that area, the bursa, right above the rotator cuff. The hope with that, it is somewhat of a Band-Aid effect, but I have had patients where it does a very good job knocking the inflammation out, and we're able to get back to the baseline of having minimal to no shoulder pain. Activity modification. Some people, if we failed everything else, they just don't want to or can't undergo surgery. We'll try activity modification, and that can be anything from stopping the activity that was causing the problem. No one likes to give up the golfing or fishing or other things that we do to keep ourselves occupied, and so if it's coming to giving up something like that, that's where we start saying we might need to think of other options. Whoops. And then time. A lot of times with this impingement, if we just give it some time, generally somewhere on the order of 2 to 3 months, it may not go completely away, but it will get somewhat better. And that's successful in about 80 to 85% of patients. In the other group of patients, we have to go and do some surgery. And again, this is some arthroscopy pictures, and this one I didn't rotate them, but this one you kind of have to stand on your head or think upside down. When I do my scopes, I'm upside down. My partners all give me a hard time about that, but this right here is this is the acromion down here. The rotator cuff is up here, so the person's head is this way, their arm is going this way. But here's the bone spur. You see a flat metal instrument there sitting on the bone, and you can just see the bone coming just like that. There's still a fair amount of space there, but you can see right in this corner there's a little bit of fraying from the rotator cuff, likely from the rubbing from that spur. This is the after. Now we have that flat instrument sitting right on the bone, and we've opened up that space even more. to take care of that spur. Rotator cuff tear, very common injury. There are reports that up to 60% of people over the age of 55 have a rotator cuff tear, whether they know it or not. There was a study done once about 25 years ago. They did a cadaver study and showed that these were mostly elderly individuals, in about 75% of those individuals, they had a rotator cuff tear that was present at the cadaver dissection. The most common tear, as I talked about at the beginning with the anatomy, is this supraspinatus tendon. So you see the muscle coming through here. Again, here's the clavicle, there's the acromion, there's that big ligament, here's the coracoid. And this is actually a really good picture. You can see one of the bicep muscles attaching there. The other one splits off and goes through the rotator cuff. But here's the tear of the tendon. Two types of rotator cuff tears. We can get partial thickness tears, which on MRI you can see this coming out nicely here, and you see it gets really thin, but just a hair, just a touch of tissue still intact there. For intents and purposes, I'd say that's probably close to a full thickness, but that was the best MRI I could find. And then we have a full thickness tear. You just see the tendon coming out here and it just stops. This guy should be attached right out there, so you've got this gap of tissue right there. These are mostly attritional, meaning over time. Generally, they don't happen from an injury. It's just something that the tendon thins and wears out a little bit over time. The full thickness can be traumatic. Again, having that arm jerked on, the fall where you land directly on the shoulder, or degenerative. They just, again, started out as one of these and over time just wore out. Symptoms here. Again, pain, weakness, loss of motion. Sometimes we get nerve symptoms. People, I still am trying to figure that one out. People say, I get this burning down my arm. I don't know why. It's there. My theory, and there's no science to base this up, but my theory is that around the shoulder, 4 of the major nerves that go down your arm are in close proximity to that shoulder. And so by having a tear, sorry, I'll stop doing that. By having a tear, it can irritate those nerves and then cause the nerve symptoms, because the nerves are inflamed as well as the tendon. One other test here, this Job's test or empty can test. Again, that's like that impingement exam test, but instead of me lifting it up, what we do is I bring the patient out here in front and have you push up against me. And if you have weakness or can't lift up against me or the arm drops, that's indicative of a probable rotator cuff tear. Internal and external rotation tests are going to be testing the other muscles of the rotator cuff. Again, when I have someone resist me going inward, that's going to test that front rotator cuff. Resist me going outward, or resist going backwards with your arm up, that's going to test the back rotator cuff. For a partial thickness rotator cuff tear, the treatment is very similar to impingement. We start off with non-operative physical therapy, cortisone injection, time 1 to 3 months, and sometimes not quite as successfully as impingement, but sometimes that will be enough to get it better. If that doesn't work, we'll then move to operative. Again, arthroscopy versus open. I typically will do a subacromial decompression or shave that bone spur out just to take away any chance of this turning into a problem later, and then a rotator cuff repair. With a full thickness tear, I usually don't wait as long. At most, I'll wait up to a month. Sometimes patients come in to me and they've done all these things. I say, okay, let's sign you up, and they say, can we do it tomorrow? If we can do it tomorrow, we'll do it tomorrow. But a full thickness rotator cuff tear I don't like to sit on, because in time, and we'll get into this a little bit later with the arthropathy, but in time, if this tendon isn't repaired, it can progress to the point where it can't be repaired, either because the tendon tissue becomes so poor, or because the muscle atrophies and just wastes away, and then there's nothing left to repair. So I don't like to wait longer than about a month, month and a half if I know there's a rotator cuff tear. Yes, ma'am?
How many cortisone shots can you take, and is cortisone safe?
The question is, how many cortisone shots can you take, and is cortisone safe to take? I don't like to give patients more than about 2 or 3 in the situation of a rotator cuff injury.
Is it for the year, or?
In general, just total. And the reason for that is because if there's a tear, the cortisone is actually something that can then cause the tendon to become weaker and less of a strong tendon when we go into repair. Now, that being said, if someone comes to me and they said, well, I had a cortisone shot, 2 cortisone shots 10 years ago, it's out of the system by then. We'll start over again. But if you've had 3, within the last 6 months and come to me and say, what's the next step? I'm going to say, probably not another cortisone shot. Yes, sir?
When on the surgery it said arthroscopic, that sort of implies a very simple, almost non-intrusive type of surgery. Is it that simple?
Yes. Arthroscopic is I use a camera, and if you have a clicker pen, pull out your clicker pen and look at the clicker. That's about how big around my instruments are that I put in. So it's a pretty small incision. I'm still doing the same amount of work, so it's still invasive, but I think it's less invasive because to get to the rotator cuff in an open fashion, I actually have to take off part of the deltoid off the acromion. And so that has to repair. That can be painful. With arthroscopy, I can get in there. I'm actually going through the muscle, and I feel like I can get a better view of the tendon. I can make the tendon move better. For me, it's just a lot easier. Now, that's my training. There are some surgeons in town and around the country and around the world who have a few more gray hairs than I do. That they say arthroscopy is still voodoo magic, but in my hands, if you have the right person and the right training, and again, I had that extra year of just shoulders and knees doing this kind of stuff, I feel like arthroscopy is pretty good. Now, if I can just finish one more, I had one more comment I wanted to make about the cortisone shot. I do have some patients, there are a few patients who come in that can't have surgery, meaning they've got some heart condition or some lung condition or liver, that just their primary care doctor, their cardiologist said, if you have surgery, it's going to kill you. A patient like that, yes, I will do cortisone shots for longer term. The cortisone itself is more going to be potentially damaging to the tendon. So if I know there's no way we're ever going to repair the tendon and the patient can't tolerate a surgery, if they need to come in every 4 to 6 months for a shot just to help with the pain, we'll do that. You had a question, ma'am?
I was going to ask you.
So the question is, a repair of a tendon or 2, what would the recovery period be? Everyone's a little bit different, but what I tell patients is my goal is that by 3 months, have you saying you're feeling like you're about 70 to 80% of normal. The initial phases, I have you in a sling. I don't let you use your arm on your own power for about a month. During this time, you're working with a therapist to maintain that motion so your shoulder doesn't freeze. At about that month point, you start doing a little bit of movement with help, and then by about 2 months, you do some strengthening. And I've had patients that by 2.5 months, they feel like they're 100%. I've had patients that take a year. The textbooks all say a year, though. So my goal for patients is about 70% of function by 3 months. So some pictures here. This is arthroscopic pictures. So here's a rotator cuff tear. This is the tendon. I did flip these pictures, so we're actually looking the correct way. This is the humeral head down here. This is the rotator cuff. So this guy needs to be pulled out to here, down. So this is actually a moderately sized tear. This instrument over here is about 6 millimeters. So you think about that, that's probably, 4 or 5 of those. So it's probably about a 2.5 centimeter tear, which is about as big as the end of your thumb. The supraspinatus tendon itself is 3 centimeters. So that's most of the supraspinatus. So this one I did arthroscopically, and you can see now on this view, here's the edge of the tendon. This is the bone down here. We've brought that tendon down nicely, and that's a good solid repair. To demonstrate that a little bit, there are multiple techniques. So a little cartoon of this. They're usually with anchors. There are some surgeons who do it through bone tunnels and suture. But anchors, this is the type I do where I'll put anchors in and then sew the tendon up through and pull that tendon down. I'll also, in certain individuals, I'll do these other types as well. We call them a double row. But again, you can see coming up through the tendon, we pull that down to the edge and then just kind of have a buttress to push that down to the bone. So that's several types of rotator cuff repair. Arthritis. So the question about arthritis, what does it look like? This is arthritis. So if you remember back to the original picture, we had a nice joint space here. We had a nice rounded head. Here we've got bone on bone. You got what we call a little goat's beard osteophyte, because it looks like a little billy goat's beard, right down here at the bottom of the humeral head. And the other thing I see here that is a little bit more subtle is instead of a nice rounded head, it gets over in here and kind of flattens out. It's not totally flat, but it does flatten out. When the head flattens like that, that's where you get the catching and the cogwheeling. You're going like this because that flattened head is trying to move on still a fairly round surface of the glenoid. The glenoid over here, you can see on this view here, this is that axillary. The glenoid is pretty flattened there, and right here the head's a little bit of a flat spot there, a little bit round, and then it goes flat again. So that person there, they told me, and it was an interesting exam, you go this far and they'd go, and then they'd go again. And it was just that little ridge, that they'd get over that ridge and they'd be fine. The other thing we see here is right in here are some little floating bone spurs that actually grew up in the tendon. I removed those at the time of surgery. But that's picture. So more commonly degenerative in our senior population, and that's just with age, time. Blame the fact you had an active lifestyle and you've used your arms a lot. We are very active people. No one likes to sit and do things down here all their lives. We all want to be out skiing, fishing, swimming, everything we want to do, and that leads to shoulder wear and tear. In younger patients, this actually is increasing. We're seeing more and more patients with high impact activities, professional athletes, semi-professional athletes, people who, it used to be that beyond high school and college, people would kind of go to the Saturday weekend warrior. Now people are continuing to be very active and competitive. And so we're seeing more not only shoulder, but we're seeing more knee and hip arthritis in patients in younger ages, 30s, 40s, and 50s, where in years past we would say, oh, we can't do anything for you. Now we're trying to figure out ways to treat those patients as well and still allow them to maintain active lifestyle and treat this arthritis. The examination of the shoulder, loss of motion. And I say rotation first. Most of the time, much of the time when patients come in with arthritis, we'll be able to get the arm up to here. And they say, well, doctor, I can still get to the top shelf, but if you watch the arm's actually below the level of the shoulder and everything's through the elbow. You can't get up here. Okay, the thing that you lose first, though, is the rotation. People say, I can't tuck my shirt in. Women, I can't fasten my bra in back. I can't wash my back. I can't get up and do my hair. I see a few gentlemen here like myself. You don't have to worry about that as much, but it is an issue not being able to do the hair, brushing the teeth, feeding yourself. If you don't have that rotation, it's hard to eat. Pain. Pain with arthritis is generally a dull, achy pain. It will get worse with activity. It sticks around. It's present at night. It may or may not get better with the anti-inflammatory medication. And then this crepitus or grinding that I talked about several times. In straight arthritis, your strength is usually pretty good. Meaning it's painful to get there, but once you get there, you can hold your arms away from your body. You can do stuff out here in contrast, as we'll talk about here in a minute, to the rotator cuff arthropathy. So non-operative treatments, steroid shot, again, that's just going to be something to bide some time, try and help with the pain, try and help with the inflammation of the arthritis. Activity modification, non-steroidal anti-inflammatories like ibuprofen, Aleve, Celebrex, diclofenac, meloxicam. Years ago, Vioxx was a great one, but that had its side effects, and a lot of people are pretty sad that that got taken off the market. And then therapy. What I tell people here is that a home therapy program, exercises may or may not help you. The most important thing for you is just to be active as you can, maintain that motion as well as you can. Formal therapy with a therapist may help maintain the motion. It's really not going to do a whole lot toward regaining more motion. If you have a great therapist, you might, but it's going to be pretty painful to get more motion if you have end-stage arthritis. So then we go to the operative treatment, and this is a picture of a total shoulder replacement. So what we do here, if you come back to here, we have this head that's all flattened, and the cup is all flattened as well. Come in here and we cut off the arthritis of the head, put a little metal stem that goes down the side, a little metal ball there, and you can see now we've recreated that round head, and then I've recreated the space here of the joint with a plastic cup. And I can see here that my cup is in place because this little guy here, this little piece of metal that's embedded in the stem of the plastic cup that we embedded into the glenoid over here. And our goal with that operative treatment is to return as much function as possible. I always tell patients, I'm not as good as the guy who made your shoulder in the first place. I do my best to get you there, but you're not going to have a normal shoulder. Then this leads into the rotator cuff arthropathy. So in the face of arthritis, if you have a large rotator cuff tear or an irreparable rotator cuff tear, so here you can see this is a long-standing one. Not a lot of that bone spur down here, but you can see here bone on bone. There's no cartilage left. Here's the tendon. The other thing that we see both on the X-ray and on the MRI is the head is totally round. Okay. If we come back here, you see this flat spot there still. That's where the rotator cuff attaches. In the case of arthropathy, your big deltoid muscle here over the time has been the one to try and help maintain that motion. And so what happens is, So what happens is you wear off what we call the tuberosity. That's where that rotator cuff attaches. And you can see a little bone cyst there from the wear. Rounded the underside of the acromion, and now you've got actually what a little bit more like the hip socket, where the stability for this joint is actually more bony stability rather than soft tissue stability from the rotator cuff and the ligaments. That's one that again, 10, 15 years ago, we would say, sorry, have a nice life, I can't do much for you, because a shoulder replacement requires the rotator cuff. We have to have that rotator cuff to hold that down in. I didn't get into this in the anatomy short of time, but I guess it's part of the discussion here. The rotator cuff not only lifts the shoulder, it also keeps the shoulder and pushes it down into the joint so that it can be effective. Again, that's why we have what we call a high riding humeral head here. Without that rotator cuff, we put a shoulder replacement in there, it's going to start doing a rocking horse effect. That glenoid is going to come loose, then all of a sudden we're going to be dealing with problems with this replacement. So for the rotator cuff arthropathy, again, exam here, we have what we call pseudoparalysis, and I had, it's more impressive with the shirt off, but obviously that's immodest. So what happens is you get patients and we try and lift the arm, and you start hiking that shoulder up, and the arm will, this is how they lift their arm, is the arm won't lift away from their body. This weakness drop arm test, what we're trying to demonstrate here is I'll bring the arm out here and say, okay, hold it here, and I'll let it go, and the arm will just drop. And that's because they don't have a rotator cuff to hold it in place. And then again, the pain and the crepitus, or the grinding. So what we do here, the non-operative treatments, again, very similar, steroid shots, activity modification, medications, and sometimes this is what we have to do. This condition is more commonly seen in patients who are sicker. Tend to be a little bit more elderly and have a few more medical problems. So sometimes a patient may not be a surgical candidate, and so this is the patient, going back to what I said earlier, this may be the patient that's coming in every 4 to 6 months for a cortisone shot, and we're just treating the pain as best we can and having to be as active as we can to keep that pain from progressing and the shoulder as useful as we can. In someone who is a surgical candidate, this is what we do here, is a reverse shoulder replacement. So what you can see the difference here is I put the ball over on the cup side, on the glenoid. We put a nice stem down here and the cup over here on the humeral side. What that does is, if we come back to this MRI, that tensions this deltoid muscle and in essence allows that deltoid to become the new rotator cuff. It's not as effective. Generally, patients can't get all the way up to here, but in a successful case, and hopefully my video works, patients can often get up to the top shelf after this replacement. It's a great video. It generally doesn't work through the email. If I'd had time to set up my computer, I could have showed you, but this is the patient who had this reverse replacement, and at 3 months after surgery, she was able to have her arm up and get up to this high. So it was pretty impressive. It was the same patient that we saw earlier with the pink shirt, where she was doing this kind of a thing. At 3 months, she was able to reach up to there. So I apologize that didn't work for us. Any other questions? Yes, ma'am. The question is, does rheumatoid arthritis settle in the shoulder joints? Yes, it will settle anywhere. Rheumatoid is a very difficult condition to treat in the shoulder, because in osteoarthritis or degenerative arthritis, actually the bone gets a little bit harder sometimes because you're wearing the bone on bone, so your body's reaction is to lay down more bone. In rheumatoid arthritis, actually the bone gets a little bit weaker. And so sometimes it's a little bit more difficult to get a standard shoulder replacement to be as effective. But there are treatments. Sometimes we'll go to the reverse replacement. But yes, sir. The normal recovery time for a total replacement. Sorry, the question is, what is the normal recovery time for a total replacement? It's a little bit different for a regular replacement and a reverse replacement. Again, I go back to our goal of 3 months. Usually with the reverse replacement, I'm having to actually hold people back by 6 weeks. And the reason there is because the shoulder has been so dysfunctional for so long that once we get that deltoid healed, people really want to move it. And that takes about 6 weeks for that deltoid. In a standard replacement, usually it's about 8 to 10 weeks before you're really using it. Again, because to get into the joint, I have to cut through that front rotator cuff, the subscapularis, and then I repair it on the way out. I really want to be careful because that's the way it would fail, is if that tore, and then we'd have to go do something different. So we really are careful with that repair. And that's about 8 to 10 weeks. Hand here, and then we'll come back to you, ma'am. That's the next thing. So if you have any desire to have a consultation with me, I'm happy to meet with any of you. My number's there. There was one more hand in the back, ma'am. You had a follow-up question?
I was wondering about the recovery from, what's the scenario in recovery from a total replacement?
So the
I've heard like you have to live in the recliner forever.
Okay, so the actual recovery itself rather than time. So with any shoulder surgery, not just replacement, any shoulder surgery, oftentimes patients find it is more comfortable to sleep in a recliner. The reason why is we all toss and turn. You don't want to roll over on that shoulder that's just been operated. It probably won't damage the repair, but it will be very painful. So most patients will sleep either up on some pillows or they'll sleep in a recliner, and that can be anywhere from a few weeks to a couple months. I put patients in a sling initially. Again, that first 4 weeks, that first month, I don't like you using that arm on your own power. Once we have enough healing going on, you start a little bit of movement with help. And then by about 2 months, you're moving it on your own power with the help of the therapist.
So what happens to people who live alone?
People who live alone, that's a challenge. It honestly is. Most of the time, for people who have a good support network at home and have help, if you have this shoulder replacement, oftentimes I've had patients that will go home the same day or just stay overnight in the hospital and go home the next day. For patients who live at home and don't have the help at home, sometimes we have to keep you in the hospital a little bit longer and then send you to a rehab facility like Eagles or Richland Rehab or something like that for a period of time until you're more healed. You're welcome. Ma'am.
Many years ago, Dr. Zirkle, I had something going on in my shoulder, I'm not sure what it was, told me that I should swim for therapy. So I've been swimming, and I swim regularly. But recently, I've found that I have this pain up into my neck. And I'm finding that I have to swim with my head down. I have to keep that head down or that neck, it just hurts right up into my neck. I can't lay on this shoulder, but other than that, I can swim, I can do my strokes, but it's hurting up into my neck now.
So the question is, with swimming, it's causing some pain up into the neck. She has to swim with her head down and she has trouble sleeping on that side. If I were to hazard a guess, it would likely, common things being common, you've probably got some impingement going on and your neck muscle, your trapezius and the sternocleido, are trying to compensate for the injured rotator cuff. And that's why you get the neck pain up into the back of your head. And swimming with your head down relaxes those muscles. And then sleeping, people with shoulder pain, again, going back to the surgical question, not only after surgery, but before surgery, it's really, really painful to sleep on those injured shoulders. So, ma'am.
Can an injured neck cause shoulder pain?
Yes.
Where do those 17 muscles go after they leave your shoulder?
Okay, so the first question that I said yes to was, can neck pain cause shoulder pain? And that is yes. And then the second question is, where do the 17 muscles go? If you have an hour for an anatomy lesson, we can go over that. In brief, there are a group of about 7 of those we call the strap muscles that go from the front of the shoulder blade. They'll come up here to the front part of your jaw, up in your neck. The sternocleidomastoid comes up and attaches back here behind your ear. Others go down your arm. the bicep, tricep. The pectoralis minor comes across the front of your chest. There are a large group of muscles that come from the back of the shoulder blade across to the spine, and then actually down your back this way. The interesting thing about necks, this is a whole nother discussion, but I share an office with Dr. Wall. I don't know if you've heard of him. He's a spine surgeon. And the two of us have many patients in common. Patient comes in with neck pain. He looks at him and says, no, it's actually shoulder pain. Vice versa. I have a patient comes in with shoulder pain, work up the shoulder. It's actually neck pain. We send him over to Dr. Wall.
Doctor,
Yes, sir.
You mentioned a few of the medication aids. Are there any of those that you would not recommend taking long term?
So the question is the medication, the NSAIDs, non-steroidal anti-inflammatories, would I not recommend taking long-term? Yes, I wouldn't. All of them, in fact. What I'd recommend is if you, and I will use them as well, but I try and take them on a sparing basis. For example, if I'm having shoulder pain or knee pain, I'll use an ibuprofen or Aleve for about 3 weeks. And then I'll go off of it for a period of time, and then if I need it again later, I'll go back on. The reason you don't want it on long-term is those can cause effects to your liver, they can cause effects to your kidneys and your stomach. The stronger ones, and that's why the Vioxx was pulled off the market, was actually causing heart problems. So you just really want to make sure you're not on those chronically. Ma'am?
I had to stand up because I'm one of those that can't raise my arms any further than that. My question is, what effect would a mastectomy with lymph nodes removed under the armpit have on effect of getting arthritis and badly in the shoulder?
The question is, a mastectomy and having a lymph node removal, does that affect the arthritis?
Well, does it affect the muscle?
Or does it affect the muscles? The joint itself, I would say not directly, but indirectly, since the lymph system is responsible for the drainage of fluid out of that arm, it can, if there are inflammatory issues going in the arm, arthritis, muscle or synovitis, myositis, which is inflammation of the muscle, any of those itises in the arm, that without that normal lymph system, that can cause continued pain and dysfunction because it just can't, quite frankly, can't drain out.
I've reached the stage now where this is as far as I can go.
Okay.
I cannot brush my hair, my teeth. I'm still able to feed myself, but
Okay.
I cannot lift a coffee cup or anything like that. My arms will work if I brace my elbows,
Right.
my hips, then I can do something, but otherwise, I'm totally helpless.
My suspicion would be that you have that rotator cuff arthropathy. The rotator cuff has torn in the face of arthritis, and people who have those, if you support your elbow, you can get up and do the things you need to do, but the elbow has to be supported. Yes.
Yeah, because to hold my arm up that high,
Yep.
fine. If she lifts it, if I help her lift it, it won't stay, it falls down.
Yep. Yeah, that's the rotator cuff. So, sir.
Is that a recent picture?
This picture was last winter, down in Arizona. We happened to be down there the weekend that they had more snow down there than we had up here. Sir.
Does long-term aspirin have any long-term effect?
Long-term aspirin, long-term effect. The studies have shown through the cardiology groups throughout that it can have effect on your kidneys, but it actually has more of a beneficial effect for the heart than the detrimental effect or bad effect for the other systems. So it's actually taking an 81 milligram aspirin, a baby aspirin every day, is not a bad thing.
How about a full aspirin?
Full aspirin, under the direction of your cardiologist, I would say not a bad thing. Ma'am, another question in the back.
Are you the shoulder dude?
The question is, am I the shoulder dude? I like to think so. What I'll tell you there is there are several other surgeons here in town who have done joint fellowships, but traditionally the joint fellowship focuses on the hip and the knee. There are several other surgeons in town that have done a sports fellowship, that they work with shoulders, doing rotator cuffs, doing labrums, doing the arthroscopy. As far as I know, I'm the only surgeon in town who has done a shoulder reconstruction fellowship. So I guess the long answer would be yes. Ma'am.
If you've already had an X-ray, it's not necessarily 100% you would need an MRI, depending on what your exam shows.
Correct. Correct. The question is, if you've already had an X-ray, are you going to need an MRI 100%? I'll have a number of patients who come to me for an initial consultation who already have had the X-ray and MRI done. That doesn't hurt my feelings. But sometimes we can save the cost and time of an MRI. If we see something and I get a good exam and say, you know what, you really don't need an MRI, it's more of an impingement or a frozen shoulder, we can treat that without an MRI, save yourself the $1,800 and the hour-long lay-in the tube. So, ma'am.
After surgery, you talk about range of motion, raising your hand. What about putting your hand down and lifting your body weight?
Okay. The question is, after rotator cuff surgery, I talked about limiting your range of motion, lifting your arm away from your body. What about pushing off? I try to have you avoid that as well, because that upward pressure on the rotator cuff, that can stretch the repair a little bit. So we like to try and avoid that. And what I'll tell people is, if you're lying down, roll over to your unaffected side, push yourself up that way, and then you swing your legs over the bed, push yourself up that way, so you're not having to push out of the. I saw another hand in back. Yes, ma'am.
Do we need to be referred by
The question is, do you need to be referred by a GP to call my... that depends on the insurance. Most Medicare insurances, you don't. But if you have a supplement, I'm not going to quote them off the top of my head because I'll get them wrong. There are a few supplement insurances and a few commercial insurances that do require a referral from your primary care doctor. What I would suggest there is, if you'd like to see me, just check with your insurance carrier and say, do I need a referral to see Dr. Gibbons, or a referral from my primary care doctor to see Dr. Gibbons? Yes, sir.
If you have atrophy of your muscles, is there any, substitute coming along, to replace the atrophy?
The question is, if there is muscle atrophy, is there anything coming down the line to replace that? There's a lot of research on that, but as of right now, no. The best treatment for atrophy is just work in the muscle, but if the muscle is, I didn't have the good MRI picture of that, but if the muscle is what we call fatty atrophied, to where there's been replacement of the actual muscle tissue by fat, that's where it becomes irreversible. That goes back to that rotator cuff arthropathy. Most of those patients, the rotator cuff muscle has been torn, or the tendon has been torn so long, the muscle is essentially atrophied and turned to fat. Thank you all for coming.